Welcome to Confident Care Academy, where we do conversations about the human part of being a nurse. My name is Anna. I am a travel ICU nurse and first year RRNA. And
I'm Chrissy. I'm a nurse anesthetist, and yeah, that's about it. I've been a nurse anesthetist for 5 years and a nurse for 9.
heck yeah. And, clinical site coordinator, content creator, educator extraordinaire, all these titles. So today we're talking about provider communication for new ICU nurses. I'm excited about this one, and I wish that I had a podcast to listen to when I was a new grad about this, because this was one of the most intimidating things to me as a new grad. So I'm excited about it.
Yeah, I mean, let's be honest, like having to call the doctor, especially if it's one that you don't know, like if it's a hospitalist or, like a float person, It's scary. Or just someone who you know can be mean.
Yep.
It's scary to call the doctor.
Did you do simulations in nursing school about you have this patient you need to call?
No.
Okay, yeah. So we did some of this in nursing school in our sim lab. It was okay, you have a patient, they need antibiotics and they're septic or whatever. But the thing is the nursing school simulation just is never going to touch on all of the factors that are happening for a real critical care patient in the ICU or the ER.
It'll be, they'll never simulate all the junk going on.
It's just more details that it's involved there than would be in your simulation. So you're taking in this massive volume of information, and then you were supposed to spit it all out in 10 seconds to somebody who scares you. So it's a lot as a new nurse. And you're 22 and sometimes calling somebody who's 70 doesn't want to be bothered. So it's
they're intimidating.
I feel like the culture is getting better.
It's definitely getting better, especially with the younger generation of doctors, APPs. Yeah. Everybody's a lot more on the same page, a lot more team oriented, seeing each other as same team, different roles versus hierarchy. But the hierarchy culture still exists. It still trickles down, especially if you're not at an institution that's constantly bringing in new younger people, a non-academic environment. You're going to have a lot more of that old school hierarchy mentality left over for a really long time. And, it's definitely a real thing. We're not going to shy away from that.
Yeah. But then which we're not condoning. It's not right, but
we're not condoning. We're preparing you.
But you're going to encounter it. So what are some ways that you can get into it? So starting from the very beginning, let's say that it's your first month, you're in the ICU, you're a new grad, and you need to call the provider for the first time. What are some tips to kind of get ready to have that conversation?
I remember getting so nervous because they'd ask tough questions. I'd be I'd freeze. But I think the first thing you can do is real quick, just review the facts about your patient. So have your report sheet down from the morning with you, and bullet point any updates that are going to be and new changes that are going to be important to tell the provider, because the provider might go, oh wait, which patient is this? And you might have to start back from square one, right? Yeah. So write down what you're going to say. Do a quick review for yourself of any pertinent, important information that might come up. What are their most recent relevant labs, vital signs, what's the need? And really, we're going to go back to basics. Again, you guys are going to hate me. Last episode, I brought up the NCLEX. This episode, we're going to do it. SBAR. It's a real thing. I used to be what is SBAR? It's real.
SBAR is fine. I'm not pro care plan, but that's
But SBAR has nothing to do with the care plan.
No, you're saying, people are going to be mad. I'm I think the NCLEX is relevant, and I think SBAR is relevant.
Yeah, SBAR is relevant. Care plans are not relevant.
I don't think a 20-page care plan is relevant. So that's my only.
I wish that we did care plans differently, because
it could be
a care plan could be a good thing, but just not the way nursing schools tend to do them. Yeah. But I like the idea behind it, just not
I think the execution is just bad.
All right, so
SBAR, back to SBAR. So let's say we'll talk about your basic provider communication first, and then we'll get into emergencies later. So let's say your patient you think they need a diuretic or a stool softener or something like that.
Yeah.
Okay. So very
electrolytes
basic,
repleted.
Not emergent situation. I think that it's good to have the SBAR format of hey, this is patient Jones he's admitted for bowel obstruction, hasn't had a bowel movement in 4 days. He went down for his scope, and I was just going to follow up about bowel prep. Have that kind of story of what are we going to do? Who is the guy? What does he need? What are we going to do about it?
Yeah. So situation. What's the situation? Brief. Yeah. Brief. 1 sentence summary of who the person is, just to refresh our memory. Because again, if you're let's say you're not in critical care, let's say you're on a med-surg floor. Hospitals could have 25 or more patients,
right? They don't remember who the patient is.
They don't remember who the patient is. Again, even if it is a critical care night shift doc, things definitely mix together, right? For all of us. So, hey, Mrs. Jones in room 53, she's here for XYZ. That's the situation. What's the background? Oh, she's going down for her scope tomorrow.
Yeah.
I know that she needs a bowel prep. It hasn't been ordered. Side note, she's having trouble keeping like fluids down. Like she might have problems with the bowel prep. So that's assessment, right? So we've gotten into situation who she is. Like, you know, Mrs. Jones with the bowel obstruction. Background is like, oh, by the way, she's going for the test tomorrow. Assessment, you know, she might have trouble tolerating it. Like, you know, what can we do about it? Like recommendation, like, do you think instead of doing the traditional go lightly, we can order some Dulcolax so she's just taking some pills instead of doing like the full liquid prep? I don't think she's going to tolerate it and be able to get scoped.
Yeah.
So, well, did they do that for past? I don't know. We're making up a probably not a totally clinically accurate scenario, but that's okay.
Chrissy hasn't had to do a bowel prep in so long she forgot how it is. I see how it looks.
Actually, I talk about bowel preps all day, every day, because I do so much GI. I actually know all the bowel prep regimens like so well.
You actually know more about it than I do. You haven't had to be on the cleanup side in a long time.
No, I have not been on the cleanup side. Well, in the GI suite,
you end up cleaning.
There are some liquid rivers, and usually the nurses like are pretty on it. But like sometimes if it's an inpatient, it's usually a 3-person job, and I'm usually the 3rd person. So I jump in there. I still get my hands dirty. So.
I stand corrected.
Once a nurse, always a nurse.
Chrissy's always a nurse. I love it. Yeah, I love that.
Especially if it's like a new grad OR nurse and they're like overwhelmed. I'm like, come on, girl, we're going in.
we're gonna dive in.
We're diving in.
I love that. No, so I think one thing for me that was really helpful was practicing what I was gonna say when I was very new and I was super nervous about it. Communicate without your preceptor. You're like, hi preceptor, can I practice what I'm going to say with the provider?
Ooh, I love that. Practice with a safe person. That's such a good tip.
So say that like with your preceptor, let's say your patient's not acutely decompensating and you have to make a phone call because they need like labs or pain meds or something. Like you need to have a conversation with the provider, but the patient's not going to die in the next 15 seconds if you don't have that conversation.
Yeah.
Practice with your preceptor. Say, hey, I was going to call them. I'm a little bit nervous. Can I practice with you? Run it down.
So good.
And then they'll give you some feedback. And then a lot of times your preceptor knows that provider too.
Right.
And then they can give you any additional context that you need. One thing that my preceptor urged me to do, and I was very fortunate as a new grad that we had a lot of access to APPs and to surgeons. So the model for providers in my ICU was we had one intensivist who was either a surgeon or an anesthesiologist, and then you had 2 APPs covering the 18-bed ICU, and then there was an on-call fellow. So you would talk with the APP, who was either a PA or a nurse practitioner, about most of your medication order needs. If there was something like your patient needed to get intubated, the intensivist would take care of it. And then if they needed to go back to the OR to get a washout, then the fellow would come in. And
that's pretty typical, I'd say, for a surgical unit.
Yeah. So we had a couple of different resources. Our unit was not one that rotated residents in and out.
Really?
Yeah.
That's interesting.
Yeah, it was interesting. So, but then the other ICUs did. So if I floated somewhere else, then we would have a resident, like PGY 1, 2, 3, whatever. So your communication does like change a little bit depending
based on who you're talking to.
But something my preceptor did was he had been there like long time. He was like, I want for you to go practice talking with them face to face. He was like, anytime that you can, just walk down 4 doors and then ask them about it. And then that kind of helped me to get over my like fear of them with that status and yada 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 yada.
I realize they're a person, right? It's a human.
Yeah.
I talk to humans. I've done that before.
I would like take my 12 lead EKG that was abnormal and like grip it with both hands, and I had to go get like the nurse practitioner to look at it, and I was like so nervous. I was like,
I'm sorry.
He's like,
here you go.
I was like I'd be like, hi, it's not an emergency for patient Smith, this is their EKG, and they'd be like, thanks, and I'd be like,
Actually, by the way, I love that you said like not an emergency, because sometimes like people like need to know how to prioritize the situation, and so saying like if it's urgent or not urgent can just help take down their anxiety, so that when they're listening to you, like they're not like cutting you off or like jumping in like, hey, by the way, not an emergency, Mrs. Smith in 54, she had a couple runs of like, you know, some VTAC, but like she maintained her pressures the whole time. She's okay. You know, I already sent off labs and the potassium's a little low. Would you be able to order 20 of K for me? The K is, you know,
what you
3-5. You know, like something like, sorry, situation, Mrs. Smith, like just had some VTAC, like background, like, oh, she's like post-op day 2, and like, you know, assessment, this is the labs, like you know, whatever, and then recommendation, we need 20 K.
So I did that often with those face-to-face interactions, just because like there are a ton of really sick patients there.
Yeah.
And sometimes if you're a provider and you're watching a new grad stumble over their words, what are you wondering as a provider? Is the patient stable for us to be having this conversation?
Stable or unstable?
While you're like stumbling over your words or not. So if as a new grad, the first thing you say for something that's non-urgent, you can be like, hi, just checking in, non-urgent for Smith, blah, 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 blah.
Hi,
blah,
just
blah,
checking
blah.
in, non-urgent. Or conversely, if it is urgent, like, hey, I'm really concerned about Mrs. Smith, blah, 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 blah.
Yeah.
The other thing too is like, sometimes you're not going to be able to have those in-person conversations if you have an off-service team, especially. Like,
or if it's one intensivist covering the whole ICU, because like academic medical centers oftentimes have more provider resources versus your smaller community hospitals where you have one intensivist who's covering 20-something patients. Like, they're not going to be able to you can't just go over and walk to them all the time because they're going to be in a procedure or they're going to be doing something, yada, 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 yada. So,
or like calling a surgeon at home, like about a surgical blade. Like you might have to wake up the cardiac surgeon in the middle of the night to let them know that the patient's coming back, or the fellow might have to, but it might require a call to wake someone up. And again, off-service patients happen all the time. Like, you might get a neuro patient floated to your unit. Neuro's not walking around. Like you got to call them. So
you got to call them.
That's like, it's good to practice both, but practice having stuff written down. And even if you're going to have that conversation in person, it's okay to have like tiny little bullet points on your report sheet, like Mrs. Jones, and then just have your little tiny short bullet points so like you don't get lost. And
I did that as
you can take a deep breath.
I had my report sheet and I would bring it, and to this day, I never know what my patient's name is. It's like a toxic trait of mine. I don't know what their name is.
Toxic trait of mine? I don't know your name.
I know all about you. I know your past medical history and what your labs are. Don't know your name. It's like bad. They'll be like, oh, what's the name? And then I'll be like, oh, at room 54. That doesn't mean anything to the providers. Like, they don't categorize by like rooms. They know their names. So
really? That's interesting.
Everywhere I've worked, they like never know what the room number is. They always want to know like the name. So I have to write that down. I have my little paper.
I was always a name person and not a room number person. And a lot of people I would have the opposite problem with. They'd be like, oh, you mean bed 54? And I'd be like,
sure.
I mean, it's the one over there. Yeah. Was that 54? Oh, I thought it was 56. Like, I don't know.
Yeah.
I'm actually the exact opposite.
So
I never knew my patient's room number.
That's so interesting.
Yeah.
Two different sides of the coin. I love that. But yeah, having the notes on your report when you're calling, super helpful. The other thing, before you call, know what their vitals are, because they're going to ask.
Know the vitals, know the labs, if it's pertinent.
And it usually is, if you're calling about something that's kind of like urgent-ish. They want to know what their vitals are, and they also want to know about their urine output, usually. Like, if it's related to that.
Yeah, it depends on the patient population and the situation, but, know the relevant info.
Right, yeah. Well, yeah, that's not always relevant. I'm just thinking about, like, low blood pressure, like, intervention type things. So
yeah, if you have a patient with low blood pressure, yeah.
Yeah, so then it's also anytime we're talking about provider communication here, but anytime you have a patient who's kind of unstable, tell your charge nurse.
Yeah, loop them in early and just like give them the rundown. Again, S-bar style. Mm-hmm. Hey, Mrs. Jones, 54. I'm a little worried. Her blood pressure's low. We've been escalating pressures all night. We gave a couple fluid boluses. The APP knows, the fellow knows. But like, just to keep an eye out just for assignments tomorrow or in case we need help later.
Exactly.
I just want you to be aware of what's going on. So situation, Mrs. Jones, like she's here for whatever. Background is like, yo, her blood pressure's low. Fight of interventions, like assessment, right? It's like, oh, we're doing all these interventions and the blood pressure's still low. Recommendation, like just keep an ear out. I think that's like a great thing to do.
And as a new grad, that communication to your charge nurse / resource nurse, if you're lucky enough to have one.
Ooh, a luxury.
I know, it's California Union.
California.
I love that. But that shows the charge nurse that you know how to bring in resources that you need, because
and that you're aware. Your situational awareness, which is key.
Really key.
It is really
as
key.
a new grad, because the thing is they need to know if that patient needs to be a 1-to-1. They need to know if they need to send resources to help you if you're going to end up massive transfusing.
Yeah.
So you're not just like alone in a corner with a bleeding patient. And it's important to communicate with your charge nurse in addition to your providers.
Definitely.
So this kind of gets into
and
like
senior nurses in your pod, by the way.
And senior nurses, yeah.
Can help you.
Always ask for help. Always have hands. So sometimes there's also like a very fundamental misunderstanding between providers and nurses about like why you're asking. So as a new grad, you're asking questions because you were not taught this in school and you want to understand. And providers are great resources for like further critical care knowledge, for like breaking it down, for pharmacology. Like talk to your pharmacist, like talk to people.
Ooh, the pharmacists are great resources, especially the critical care pharmacists.
They usually love teaching too.
They're clutch.
Especially about like antibiotics and transplant stuff. Like,
they love that shit.
They're like so good.
Yeah, they love it.
So sometimes when you're asking a question as a nurse, it can be interpreted as
like a challenge,
like
right?
a challenge. Like, I don't agree with you.
Yeah.
Like, and to just diffuse that as a new grad, something that's easy to do is just be like, hey, for my understanding, could you explain this a little bit more?
Yeah. Just to clarify, so we're on the same page. This is what my understanding
knowledge,
of for my knowledge. This is what my understanding of the subject is. Is that correct?
Learning, for my learning is good. So let's say this is an example I had as a new grad. I didn't understand why some patients got 5,000 units of heparin Q8 versus some got like 1,200 of units heparin, 1,200 units of heparin Q8 or 10,000, whatever the next. My brain. Anyway.
Okay.
Some patients got a higher dose of heparin sub-Q, and I was like, why?
Okay.
And then my preceptor was like, is it say in micromedics? So then I was like, not really. And he was like, okay, we'll ask the provider. And I'm like nervous. Like, So then 2 ways I could have phrased this. The first way is, why is patient Jones getting this dose of heparin? That kind of sounds like I don't agree with the dose of heparin.
Yeah, it sounds like a challenge.
It sounds like I don't agree with that it's correct.
Why are they getting 10,000 instead of 5,000?
Yeah, versus what I said, because I talked it over my preceptor, is I went up to the provider who I was kind of scared of at the time, and I was like, for my knowledge, so for my learning for patient Jones, can you explain why some patients get this dose of heparin and some patients get that dose of heparin? It was weight-based. It's like, it's
that simple.
It's not like a complicated answer, but there's 2 ways to phrase that, and one is kind of like, comes off as like harsh and like disagreeing, and then the other one is like, could you teach me this? Which is like a better place to be in as a new grad.
Definitely, and I think that most people do like being in a teaching role, even if they seem like they're nasty, like
mean,
crusty, mean people. A lot of people, they like feeling respected and valued.
And like
when you're asking someone to teach you something, and like sometimes people are frustrated because they're busy and they don't have time. But if there's time, I think people like feeling like you're recognizing their expertise. It makes them feel valued. So.
Yeah, 100%. And sometimes the old crusty ones, like,
oh, they love it deep down. They're fake crusty.
They're fake.
They're all Sour Patch Kids. They're salt. They're sour on the outside and sweet on the inside.
Yeah.
Hard coated, candy shelled M&Ms. Every single one of them. They're all cuddlers. You just got to break them.
The meanest people at my new grad job who were like so rude to me initially. After a little bit, I got into it, and then I realized I'm like, they're the 100% the type of person who would like send themselves or send their kid an hour and a half to make sure that I got my tire changed. Like they would 100% look out for me.
Yeah. These people,
they're like hard. They're like rough around the edges, but like, again, like, you're a learner. Be a learner and like ask for help and
definitely.
Like, do your job and like be thorough, but then every time you don't understand something, because you're not going to understand a lot of things as a new grad, ask for clarification. You're like, oh, just for clarification on that, could you tell me like why we choose this medication versus that one, just so I can like learn? They like that because it also means that you like care and you're like doing a good job, you know?
Yeah, definitely.
You learn a lot. So also this is an aside. You're going to start with new grads and you're going to start a cohort. Some people,
hopefully, if you have a residency.
hopefully. You're going to see some people who like look things up and ask questions, and some people who kind of take things at face value. And you're going to learn a lot more when you are using the resources around you and asking questions and looking things up versus just kind of taking it as it comes.
Definitely. So back to the Google Doc that we always talk about. Have a Google Drive and put a little doc in the drive with like a running list of your questions. Or you could even just do a note on your iPhone, right? Like in the notes section. Just things that come up over the shift, like why this dose of heparin versus that dose? Like why did we, like, what is MV ring? Like, you know, like little stuff that like, it's like not necessarily life or death in that moment, but like you want to circle back to, and then you can look that stuff up later, and then you'll pretty much always remember it because it came from a patient application, it came from a question you have, you wrote it down, you looked up the answer. You're not going to really ever forget the answer to that question.
Well, that kind of goes back to the like different modes of learning. Like, you wrote it down, you asked it, you looked it up, and then you acknowledged and like learned something from it.
Yeah.
Which is very different from just watching it in a YouTube lecture or something.
Right. Just like experiencing that like one chunk of knowledge one time, or hearing a simple answer one time that kind of like just doesn't stick in your brain because you didn't get the full context. Like always put your learning into context whenever you have the opportunity.
Absolutely, because it's all applied knowledge with patients, right? So getting into kind of urgent or emergent situations a little bit. So let's say that you're in a structure where you have providers who are in-house, because you should in the ICU. You should.
Yeah. Usually ICUs you have someone in-house.
You should have someone who is in-house and like fairly close. And let's say that you are concerned about a patient, they have a sudden change, but it's not to the point where you're going to hit the call bell. This is where
like a rapid AFib or like frequent ones of VTAC, but like they're not in a code, something like that.
So let's say that they're new, like they were in sinus in the 60s and now they're in AFib in the 150s, but they're conscious. But this is a new change.
But like pressure soft, right?
Yeah,
like
lower blood pressure.
Like, 70s over 50s, still mentating, like not ready for the code bell yet, but like this is urgent.
But urgent. So this is where you call your provider, because do you really want to leave that patient? Like, no. If you can stay.
Yeah, you're not going to walk down the hall.
You're not going to like walk to the other end of the unit with your patient who's newly unstable. This is where you should make a phone call, and you should be pretty quick, pretty direct, and concise.
And this is SBAR at its finest.
So a good example would be like, hi, this is Anna. I'm with Smith in room 12. They would have been sinus and normotensive and just switched into rapid AFib RVR. They're mentating. These are their vital signs.
Okay, and you come by.
Would you like to come see the patient, or would you like me to...
Or would you like an amio load or, whatever?
Yeah,
we're sending off labs.
It's okay to ask for direction at that point. You say like, hey, this is the patient. These are their vitals. This is what their mentation status is. What would you like me to do?
What would you like me to do first?
Because they might be like, if they know you and they know that the patient's not dead, they might just be like, okay, give it amio and then check back with me. And then you give them
they might say like, oh, check labs and like
their magnesium.
What's their magnesium and potassium?
Yeah.
So, these are things that like are obviously going to vary from unit to unit, and that comes with a little bit of time and knowledge and expertise. Like, how emergent is your emergency? And some of that
you might not know, but so
it's going to come from being seasoned.
You could have said it differently in a bad way. I could have been like, hi, this is Anna with patient
Come now!
In room 12, they're in AFib. Okay, what rate? Like, that's not enough information. Like, you'd be like, okay, well, they're in AFib. You're like, okay.
Oh, it's rapid.
You're like, okay, they're in rapid AFib. Then the next question is like, are they conscious? Like, are they mentating?
Are they stable? Like, that's the next question a provider would probably ask is, are they stable? And do you know what the definition of stable is, right? What defines stable as a new grad nurse? To me, stable means you have adequate perfusion. Your blood pressure is high enough. They're able to mentate and perfuse everything. It's like a blood pressure compatible with life. Yep. They're stable, but it's urgent because the blood pressure is soft. We are going, like, what would you like me to do first?
Right.
I think that's a really reasonable way to approach that conversation, and that's something that you're definitely going to come across.
Yeah, and then the membership, we have a new to ICU membership where we have a lot of case studies where you can tease this out. So you can be like, okay, well, this is the patient presentation. What are you going to do first and why, and how are you going to tell the provider? Because like that is something that it does take practice to like kind of get a handle on. So then let's say you've got a patient who's like not super compatible with life when you first walk in there. You can hit the code bell or like the rapid. A lot of times in ICUs, they don't use those. Like a lot of times, like the classic, can I get some help in here? Like is a lot of places I've worked, that's what they do. They just like yell for people to come in. Or you can make a phone call, and then at that point, that's kind of where you should be like, in my opinion, you'd be like, hey, this is Anna with room 12. They're unstable. I'm like in here. Can you come take a look at the patient?
Yeah. I think again, it depends on the spectrum of how urgent. Like, so if you walk in and your patient's like literally has no pulse, please hit the code bell. Please hit the code bell. Please do not shout into the hall because that's just going to delay care. It's not going to get enough people there quick enough. Like, if it's really that bad, hit the code bell.
Yeah.
But if you are like seeing like, oh, like Mrs. Jones, oh gosh, her blood pressure is in like the 60s over 40s. You shake her, she wakes up. Like, you're like, okay, like, yeah, you can shout for help at that point. Like, she's stable enough for you to, grab the people in the hallway. You don't need the whole unit in there. You need probably 3 people.
Yeah.
So, just like knowing the different levels of care and how to escalate it appropriately. And that circles back to like, we kind of addressed it like in person versus calling, but like, when do you use those texting services? Like we have Curator at my job, which and Anna mentioned
like secure chat with Epic or something.
Yeah, it's like there's all these different apps for that, but like these secure texting apps where you can like text page different people. So like, when do you text page versus call versus like grab a human? Like that's like kind of hard, I think, for a new grad to figure out.
Yeah, it kind of circles back to like the levels of urgency. So like for the ID consult who's slightly tweaking the antibiotics dosage, I might text page.
I'm down with the text page for that.
I would text them on Epic Chat, Secure Chat, whatever. Like, because like while antibiotic timing is really important, I don't really know for this transplant patient what the correct dose is, and the infectious disease guy is gonna have to figure it out. Like, and he can tell me when he figures that out. And then like you can text him plan to circle him in, and then, or her or them, you can text whoever, and then that's not a life or death thing in that exact moment.
Right.
Versus like the conversation with the intensivist on the unit about like making a plan for fluids versus diuresis.
I would say complex conversations, if you can have them in person, they're better. Complex things, right? So like nuances about like, should we escalate to end of life care? Like, should we get a palliative care consultant? Can we have a family meeting? Like, what do you think about this? I don't, can you teach me something? Like, can you teach me something conversations or in-person conversations? Those types of things. But if it's like urgent, like what's going to get the person there faster? Well, if the person's right in the hall, okay, grab them. But if you don't know where they are, call, hey, can you come see this patient? I think that's really like the move.
Yeah, absolutely. And then as you learn as a new grad, as you go through, you'll learn to be like proactive versus reactive with like even orders that apply to your patient about like, okay, you come in, you check your orders in the morning, you see it's a patient who's going to downgrade. I have a list of things that I want to talk to the provider about before rounds or during rounds where I'm like, okay, can we discontinue the A line, the central line? Can we pull this off? Do you want to diurese or pull the Foley? Like all those things, like you can have a little conversation about, so you can check off all those things as like but that's like with the team.
Have you ever worked somewhere where you were allowed to discontinue your own orders to a certain degree? Yeah, I remember doing that. Like we would DC our own orders for like routine stuff. Like
example of like, okay, so like the CHG that you do the mouthwash when they're intubated.
Oh, like so they're extubated now. You can DC the CHG.
Yeah, they're extubated. They don't need the.
And you put in like a reason, and then it gets approved by a pharmacy or whatever.
Like cosign or whatever. It's like, okay, they don't need the intubated mouthwash anymore. They're extubated.
There are certain things that as an ICU nurse you might be able to do depending on your unit.
As a new grad, you just got to learn what the unit policies are and stuff. Like if it was like a pre-talked about thing that the patient was going to like go upstairs and they're not massively fluid overloaded, like pull the Foley. Like they're going to go upstairs. They don't have BPH or like it takes some situational awareness to know about like when is the right time to do certain things.
As a new grad, that might be like a little bit above your head, but I would say,
or at least circle back with things to talk about with the team. Like, oh, do you want to do
things
this?
to talk about on morning rounds. Like have a list in the mornings. Like when you look over your orders, like start to write down a list of like questions for the day or goals for the day. Like, can we DC the Foley? Like, can the A-line come out? Like, are they ready for the step down? I think they might be. Like, those are things that you can just like put on your little checkbox to discuss.
And then as a traveler who oftentimes, I don't know my providers usually because I float to a new unit and I'm only there for a day. I have no idea who the hospitalist is. I don't know. Like, I don't know who the intensivist is. I'm only on that unit for a day.
Who's this guy?
Yeah, who's this guy? It's not like we have like this ongoing relationship. And if you do have an ongoing relationship with your providers, that makes it easy.
It makes it way easier.
A lot easier. But if you are not in a place where you know your providers, clear communication is even more important.
It's such an important skill.
They know that like their patient is taken care of with you and that you are clearly communicating what you think the patient needs. A leading question. Yeah. So with a leading question, it's okay to phrase things in a way where you're like, hey, for patient Jones, did you want to pull the A-line? Or, hey, for question Jones, did you want to maybe start a central line? Because I know we're going to have a lot of antibiotics and pressors going in, and I have 2 IVs, and I just wanted to check with you. That's you saying, hey, can you start a central line for this patient? But you're phrasing it in such a way that it's like, hey, like...
It's palatable.
It's palatable, but it's you asking for something.
It doesn't sound bossy. And, again, like, it's unfortunate that we even have to have this conversation at all with you guys. Like, oh, this is how you ask for something without really asking for something so that somebody doesn't accidentally misinterpret you. But the truth of the matter is, like, because of the history of the, like, medicine and the healthcare hierarchy,
patriarchy,
it's just stuff, like these systemic issues have trickled down over generations of like abusive relationships, like for everyone. So, like, including, like, the doctors, like, they've been victims of it, too. So, like, that's, like, where this all comes from. Like, people just being very defensive. It's, like, almost, like, generational trauma. I'm not even kidding. So,
for real.
Like, learning how to deal with a traumatized people group. We're using language that makes people feel safe and not threatened and opens lines of communication. So, it sounds silly to, like, have to speak to adult professionals in a way where
you're a subtle way.
In subtle ways, like, but it's effective and it's going to make your life easier. So like, hey, what did you just say? You're like,
I was like, hey, for patient Jones in 27, did you want to go ahead and start diuresis for them? Like, that means you think that they need to be diuresed. But
do you think we should consider diuresis? That's like another way to say it.
And if it's like urgent and the patient's crumping, that's where you're like, hey, for patient 27, I'm concerned about them. Can you come take a look? They're really hypotensive. That is like, get over here now.
I'm concerned is like clear language. I'm concerned, blank, blank, blank. Can you come see them? Like that. They know to prioritize.
They should get up and start walking at that point.
Yeah.
Or like wrap up what they're doing, then come.
And any good professional will be happy to respond to that. And
100%.
Most people will. And I think you'll find a lot of success with that phrase. I'm concerned.
Then on the provider side, like they also have all this like administrative like typing things to do. So a lot of times what you're asking for is a set of orders. So you're like, hey, for patient Jones, did you want to maybe check a BMP because we just started diuresing them, or like you want to check some electrolytes or whatever. If you don't have an order set where you can just do that yourself,
right?
Then they can stand there and put that in real time. And then they can be like, oh yeah, then they can do that, and they'll be like, all right, you're good to go, because then they can just do that in the moment,
right?
And then if you're dealing with like interns and residents, then you ask it in the same way but then you add more on to the end of the sentence so that they like make sure that you are like over communicating where you're coming from so that they can kind of grasp it.
Yeah, if they're new to your unit, they're like floating through, they've never been there before, first year intern, you might want to say things like, hey, like just, in this situation in the past, this is what we've done, or this is what we usually do. Mm-hmm. Are you comfortable with that? Would you be able to put in this order? Like just being really super clear, like, this is like our norm and this is why, and could you please do this? That goes a long way, and you're helping them out because they are rotating through so many different specialties
that are all
they
like
all
really
have their
different.
own, they all have their own nuances and order sets and like different things. Like I remember it really surprised me one day when one of our residents said to me, well, what is your normal pain order set here? And I realized, I'm like, oh, the post-op cardiac surgery patient is going to have a completely different pain order set than the last rotation he was just on. Like it was such an eye-opening question to me because it was so simple, and I'm like, oh yeah, like obviously our patients don't have the same order sets as all the other patients.
Knowing the flow of their year too, like if they start July 1st and that this is their first or second rotation, being like kind, and then you can also like say like start over explaining things but without being like, don't be condescending. And then it's also okay to be like, hi, like nice to meet you, my name's Anna, like what rotation is this for you? And then they're like, okay, this is my like second or third month being here. And then you can be like, okay, cool, so for patient Jones, I know you're covering them, would you be able to throw in some pain medications for them? This is what they usually get here. And then like, or even phrasing it in a way of like, oh, well, you might already know this, but with like this surgeon, their order sets are usually they like X, Y, and Z pain medications.
Oh, I love that phrase. You might already know this. I'm just covering my bases. Or you might already know this. Just stay on the same page. I love saying stuff like that. Another thing I like to do, so this is like really important communication for me as a CRNA, and I think this is very similar for people who are new to any environment, including new grads or travel nurses, is introductions with names and roles. So whenever I walk into an OR, I say good morning to the circulator, to the scrub tech or scrub nurse. I say good morning to, the resident, the med student, the attending surgeon, and every single day, hey, we haven't worked together in a while. Could you remind me of your name? Oh my gosh, that's right. I'm so sorry.
Yeah.
I'm Chrissy. I'm the nurse anesthetist today. If there's anything special that you like for this case, I haven't done it in a while, can you just let me know? Oh my gosh, the lines are wide open.
Proactive, it is friendly, so it sets the tone. So then 30 minutes later, if something starts to go bad, they're less likely to snap at you because you already had that line of communication.
They never do. It works every time.
And then that's
really
also
does.
like showing that you're like good at communication and that you care that you're going to take care of the patient in the way that is best for the team. And especially if they're like our preferences for a case that you haven't done in a while. Like,
sure,
I
do hundreds of types of cases. Like it's very, it wouldn't surprise me if, I go into, this happened to me a few months ago. I went into a case and I had to give fluorescent and I just couldn't remember the dose. I only give this one drug in this one specific case like once a year.
Yeah.
I didn't remember the dose. So I called like 3 people to figure it out. But so I spoke to the surgeon. I was like, I'm so sorry. I have not done this in so long. I'm just going to take a minute to call and find out the correct dose before I give it. And that was it. That was the end of the conversation. So
you can even
just establishing roles and names.
Yeah. And you can even phrase it in a way. And I think as women, we tend to do this a lot, like, which totally could have been like absolutely appropriate. But I think as women, a lot of times we apologize for things that are just like instead of being like, oh, I'm sorry, you could be like, hey, just checking in. I'm going to make some phone calls because I haven't done this in a while and I'm going to find out the dose. So you're not
It's
always
a little bit more time sensitive in the OR in this specific case, which is why it's like,
you'd be like, oh, I'm sorry.
The surgeon wants it that second to shoot the dyes.
Be like, oh, sorry.
Now, like, oh, yeah. that is an apologize moment.
Then an apologize is appropriate.
But yes,
but as a new grad, don't be like,
don't apologize.
Hi, man, I'm sorry. Hi, sorry. Hi, sorry.
Yeah. Don't apologize for existing or asking questions.
But that was appropriate, totally, and I didn't understand the context of it.
Which is fine.
Totally.
But yeah, I mean, like, for sure. And as a new grad, you're going to just like run into so much of that, like the over apologizing, like the wanting to be overly wordy, word vomit. Like, try to write your thoughts down ahead of time. Try to take a deep breath. Try to recognize that like you really do belong here. You really are a professional. You're stepping into that role. It's new for you, but like you're going to get there. And just remember that like everyone else is on different stages of that same exact journey. So giving lots of grace to nursing students, giving lots of grace to interns, med students, residents, like they're all on the same journey you are. We're all figuring this out together. And if you can just be clear and kind and again, establish roles and names early, you're going to establish relationships and your communication is going to be so much smoother.
That goes for everybody on the team. Your life is going to be so much better when you are the new grad nurse who introduces themselves to the critical care pharmacist and the dietitian and whoever med student is there and the respiratory therapist and the RT student.
Like, even the scary surgeon.
If you're friendly and also positioning yourself as a learner, because that's what you are. You don't know everything. You just got here. But you're a learner, and if you're a clear communicator and you're pleasant and you take people's feedback, like for the most part, you're going to learn so quickly and just be a sponge and like soak it all up.
Yeah. And people will know that they can trust you. And I think that's probably the number one thing. Like, they want to know if they can trust you or not. And once you've kind of proven that with good communication skills, you're going to be good to go.
And at the end of the day, you don't have to know everything. You need to be a good communicator. You need to know when to ask questions, and you need to like soak up feedback and all this information from providers, from charge nurses, from respiratory therapists. Oh my gosh, we should make a podcast about respiratory therapists.
Oh, I got a lot to say about respiratory therapy in a good way.
In a very good way.
I was a fake respiratory therapist for a while during COVID.
Oh, during COVID. Oh, yeah.
Oh, man. Me and RT, we're like this now. We're besties.
He's in a pod. So I think that wraps up this one. Please comment what you want us to talk about. Because I'm really enjoying this kind of like the human and like communication side of nursing podcast stuff. So let us know what you'd like to hear from us.
And please subscribe, follow along, check out Anna on her socials. She's Anna. You're Anna Reese. Anna Reese is on Instagram.
And then Reese,
and she's Reese's RN on TikTok. And what are you on YouTube?
Anna Reese.
So she has a personal channel as well. I'm Chrissy CRNA on TikTok and Instagram. No personal YouTube yet, but maybe we'll get there if you guys comment what you want me to talk about. And, you know, above all else, we are here to support you, especially the new grads. We have a special place in our heart for that because I think we both had such a similar experience. So if you are looking for more information about specifics, getting into specific case studies, you know, vent settings, drips, sepsis, ARDS, all like the nitty gritty details, and you are enjoying our discussion style, teaching style, that is what the New to ICU membership is all about. We have monthly lectures, monthly live Q&As where we're going to get into case studies, and then lots of bonus resources that we pop out along the way whenever we feel that it's on theme for the month.
So thanks, guys.
All right.
See you next time.
Bye.